Dr. Douglas Harrington is a California-based doctor who has over 30 years of experience in innovative technology for healthcare, research, and development. In this edition of Quintin's Close-Ups, he talks to me one-on-one about vaccines, antibody tests, and of course, COVID-19. And if you haven't already, subscribe to my YouTube channel and like Quintin's Close-Ups on Facebook. Dr. Douglas Harrington, welcome to the award-winning Quintin's Close-Ups here from Charleston, South Carolina.
Well, thank you very much. It's a pleasure to be here virtually.
Oh, yes, sir. I appreciate it greatly. I know you're extremely busy too, but obviously you are a fellow of the American Society of Preventive Cardiology and the American Society of Clinical Pathology, and obviously you're an expert in laboratory diagnostic testing. You are also the chairman of Dr Heart Foundation, which is actively partnering with community organizations, nonprofit organizations, businesses, and city officials to provide a community that is with no cost COVID testing, antibody tests covered under the CARES Act with or without insurance, obviously. Who is Dr. Harrington these days?
Oh, I'm a gentle voice of reason in the midst of all this chaos. How's that?
That sounds great. That sounds great, actually.
There's a lot of hope out there. I mean, there's so many good things happening right now. And, the worst thing that we could do is let people operate in fear, because, we've really gotten better at treating people, and we're committed to working with communities. We go into, with the Dr Heart Foundation, it's an all-volunteer organization. It's a 501c3, and 100% of donations that go into that go back to the community. There are no salaried employees or anything like that. And their mandate is learn, detect, prevent, and we tend to attack the most prevalent issues that cause death and morbidity in people. Cardiac disease is still the number one, even with COVID, and that was their original one, and they're involved in diabetes and COVID and metabolic disorders, just mainly in a preventive way. They use education of the public. They bring testing modalities into areas like we're doing with COVID. And the tent you're in, we have 10 of those.
Wow.
And we set up, the team sets up, they do, like for COVID testing, we do social distancing, and we use appointments, and we have a team to get people in and out very quickly and very safely. And it's nice that it's outdoors, that we can do that here. But we do it we've done it in Michigan, we've done it in many places. So,
and when did the foundation begin, Doctor?
About 10 years ago.
And what is the biggest difference between 10 years ago and right now when you think of that foundation?
Well, 10 years ago, it was a glimmer of an idea, and it was precipitated by my wife, who heard me giving a talk about cardiac disease, and her friend. And what I was talking about is the fact that about 80 to 90% of all heart disease is due to lifestyle. And if it's due to lifestyle, that means that you control your destiny as it relates to heart disease, because what you do, what you eat, what you don't do affects your health. And they realized that there was a big gap between the disease model of medicine, which is wait until you're sick and then we'll treat you, versus let's not let you get sick in the first place. Let's figure out what you're doing wrong, figure out what you're doing right, educate you on those things that you're doing wrong, and let's prevent you from getting in there in the first place. And that was what they did. And over those 10 years, they've done tens of thousands of screenings for patients for heart disease, for COVID, for diabetes. And in 10 years ago, it was a small group of people that just had an idea. Today, we have many volunteers that shift in and out of various events. They've been featured on a number of news channels, and it's just a really nice, mature, kind of like a community sort of thing. It's not the American Heart Association. They don't want to be. They want to be community centered, meaning they partner with city councils, organizations, and bring whatever they need to help them educate or test people.
And since COVID, how many people have your foundation actually tested?
Oh, we're way beyond 10,000, way beyond.
Wow.
And we're going into areas that don't have access to healthcare, like South Central LA,
Right.
parts of Northern California, District 9, working with Curran Price, and we work with, we've been in Crenshaw, Baldwin Hills, Baldwin
Yes.
Park, and,
Right.
so, and what's really wonderful is that the communities there were just super supportive and very grateful for people being willing to come in there. And they worked side by side with the Guard of Heart folks. It was really nice.
Very
And
nice.
yeah, very nice. And even when you think about it, some of the city councils came by and donated food to the volunteers and water, and it's just been a really good experience,
Yes, indeed. And you talked earlier about the lifestyle. What is that lifestyle right now with COVID? How are people generally taking care of their bodies and their health? And
Well, we this is the bad part, when you're required to be home and not go out. You got a few things you can do. You can watch TV and eat potato chips and sit on the couch, right? It's not a good thing.
no.
So we're trying to encourage people to do things like get dumbbells, get kettlebells. Instead of sitting down and watching TV, get up and exercise, because exercise is actually great for your immune system. It'll help you protect yourself from COVID. And we try and get them to eat healthy, stay away from the milkshakes, the beer and whatever, and eat those vegetables. And but it's really trying to get them to do things at home that they may have used to, like going to the gym, that sort of thing. And but I think the hardest part is that there are a lot of people that live alone, especially the older people,
Right.
and they get very depressed by not being able to interact with people. And in particular, we do nursing homes, and in some of those, the family members were precluded from visiting their loved ones. And I think that there's a better way to do that. We test the people, and they're allowed to go in, so they know that they're safe, and that allows them to visit with them, and that's really important. The other thing we're seeing is in kids less than 18, the suicide rate is so much higher than the death rate. There's been I think it's a 200 to 300% spike in suicides, probably because of this social distancing. You know how kids need to interact with other kids, and
Right.
that's not happening right now. But luckily, some of them are going back to school, and I think people are being careful. They're not being stupid. That's important. I don't think they should operate in fear. They should just be careful.
Yep.
Like wear a mask and wash your hands. And the one area that we have found people neglected, and even the CDC and the other healthcare experts, is that when you're in a public restroom, we can test for COVID from sewage. So, for instance, we may go test the sewage in a large apartment building.
Right.
And if there's a high level of virus there, we know we need to get in there and educate people or test them. The reason we can do that is because the virus comes out in your urine and your feces. And because of that, most people don't realize that when you flush a toilet, it can fling droplets up to 20 feet away. So when you go to the bathroom, you should, number one, if there's a lid, close the lid before you flush. Number two, keep that mask on. And number three, wash your hands very carefully after you leave. And in Los Angeles, we have a huge Hispanic community, which frequently has multi-generational housing. And what we are finding there and in New York, where they have a single bathroom and somebody's infected, the virus goes through that crowd pretty fast. So if you have more than one bathroom and somebody's positive, they should stay in one bathroom and everybody else should use the other one. And it'll help immensely, but you just really have to be careful in bathrooms.
What else should we be educated about when it comes to public restrooms and COVID?
Well, the public restrooms in general are going to be more dangerous than your home bathroom. And a lot of them don't have a lid on the toilets. You know what I mean? And if you're at the airports, you've flushed some of those toilets that sound like a jet taking off. They're flinging droplets in the air like dramatically. So the good news is some of those have automatic flushers. So get in and out. You know what I mean? Get in and out, and then make sure you keep your mask on and wash your hands.
Yes, sir. And I have to address the elephant in the room because, you know, you hear about this. I've heard about it for the past 24 hours on local news, national news, and that is the vaccine. And obviously some of that is coming into the United States as we speak. And I know obviously the first responders are getting first dibs on it. Let me ask you this. After those first responders take that vaccine, what else should they do, doctor?
The interesting thing about the vaccines, the FDA said that the vaccine to be effective has to have at least a 50% effectiveness rate, meaning that if I give 100 people the vaccine, at least 50% of them get an immune response that's protective. And what's interesting is that virtually all of the vaccines that are being tested right now, and the two that have already had an EUA, emergency use authorization, are at least 95% effective. Okay. And what that means is that first responders who get it, the biggest risk there is that they'll have a reaction to the vaccine itself. You know, I don't know if you remember when you were a kid and you got a vaccine, sometimes you didn't feel good for 3 or 4 days, or maybe even a week. Well, there's the potential that that might happen with these vaccines. And the concern with giving it to first responders is we may be removing people who we need on the front line for a while. But I think in general, once they're vaccinated, that doesn't mean they, you know, get to party like Chris Farley. That means they should still maintain the masks and the gloves and careful precautions. But they're going to be they're less likely to get infected. In fact, they're very unlikely to get infected. And they can be more aggressive in helping people. They don't have to worry so much about themselves getting infected or them infecting other people. So they can be more, you know, out in the open. So I think it'll be a good thing. And, you know, nurses, doctors, healthcare workers had about an 18% higher infection rate due to their exposure, continuous exposure. This will really help them. It'll really help them.
And what are the other side effects of getting this vaccine?
So, you know, no medicine, no vaccine is without side effects. We know that. And most of the focus in the media has been on the efficacy, which means, are they good? Do they do what they're supposed to do? The answer is yes, they're very good at that. But there is, if you read the news releases on this, you will see that rather than calling it a complication or adverse effect, they're calling it an exuberant immune response, which means your body's reacting to it. You don't feel so good for a while.
Right.
They're seeing that. There's no question about it. And it's unpredictable because everybody's immune system is a little bit different. But the good news is there, at least as far as I know right now, there have been no deaths associated with it. There have been no instances where an infection resulted because a lot of the technology doesn't use live virus, you know. Like, go ahead.
Oh, I'm sorry, doctor. Sorry to interrupt you. What exactly is a live virus?
Well, one of the polio vaccines was using what was called an attenuated virus, which essentially created a very subclinical infection, and some people got very sick from it. Actually, some people got polio from it. There was one version of it, and that would be a live virus. None of the vaccines that I'm aware of are using a live virus, but some of them are using virus that's been killed or inactivated. That one in India that I know of, which actually works pretty well. So we don't really have, the technology that's being used is really based on their experience with Ebola. So for instance, the one that has really been in the news is what's called an mRNA vaccine. What they're doing is they're injecting a genetic material into your body, and it makes cells make the spike protein, and your body recognizes that and makes antibodies to it, and it's not the virus, it's a part of the virus. So it's not infecting anybody, but it's making your body get a very exuberant immune response to it, and that's really cool. That was developed from Ebola.
Wow. And what other immunity responses will we get from, well, most people will get from this particular vaccine?
Well, what's interesting, and I don't know if you are aware of this, but the level of immunity in the population that's needed to achieve what's called herd immunity
Right.
is around 60%. And I'm going to tell you that there are two parts to your immune system. Okay, there's a T cell part, which not very many people talk about, and that's called cell-based immunity. They don't make antibodies; those cells that directly attack the virus. Okay, and then there's the B cell part, which makes antibodies, and that's the one that most people are aware of. Okay, now what's interesting is in studies in Singapore and various other places, if you've ever had the common cold, which is a coronavirus, about half the population has T cells that are active against COVID-19 already. Half the Singapore population that was tested. And that's important because some people won't develop antibodies if they have a really strong T cell response. And what it also means is that 60% herd immunity doesn't mean that everybody has to have antibodies. They can have cell-based immunity as well. So the reason I'm making a point of this is because I think we're going to get to herd immunity much faster than people believe, because there are a significant number of people out there with these T cells that are active. And the other concern that people had was, I have antibodies, but then they go away, and now I can get reinfected. Mostly not true. The number of people who actually have documented reinfection is extremely small, and the majority of them have some immune defect where they may never have cleared the virus or they do get reinfected. Most people are going to have two things that are going to help them. And just for everybody listening, the half-life of an antibody in your body is about 73 days for COVID. That means that if you start with a level of 10, in 73 days you'll have 5. Okay, and so it's about 73 days. But even if it drops below what our laboratory tests would consider positive, you have memory B cells and memory T cells. These guys float through your body. They're ready to go to action whenever you're exposed to the virus again. Within minutes, they'll reactivate and start making antibody and attacking the virus. So you shouldn't worry. All the evidence is suggesting that immunity is very durable in healthy people.
And you talk about immunity. What is that self-based immunity that you just referred to?
Okay, so the B cells are like snipers. They have a bullet that goes right to the virus. The T cells are more like Pac-Man. They see a virus, they eat it directly. They don't make a bullet, and they go after it. And they both work together. And a lot of times the T cells, or the cell-based immunity, starts first. And if it's successful, it clears the virus before the B cells have to make a lot of antibodies. But typically they work together. You start, the T cells are working and the B cells are making their antibodies, and boom, you're good to go.
And you talk obviously about antibodies, and obviously a lot of people will be taking those types of tests prior to the vaccine. But what is the difference between the COVID-19 swab test and the COVID-19 SARS-CoV-2 antibody test?
So the swab test, which most people are familiar with, is directly detecting genetic material from the virus. And it's primarily for people who have symptoms, who are shedding the virus. The antibody test is not used for a diagnosis of somebody that's acutely ill. It's used for people who may have been sick a couple of weeks ago, or feel like they were exposed, or may have had a slight cold. And what it does is it tells whether you've experienced the virus and developed an immune response to it. Now, the antibody test, if you've been exposed to the virus, is very reliable. So it's 100% sensitive and 99.6% specific. that's important because the majority of people who are infected with COVID are presumably asymptomatic. It's about 40 to 60% have no symptoms, or they didn't recognize the symptoms. It's that mild. And that's important because our public health officials need to know what the true prevalence of the disease is. And why that's important is because when you're only testing symptomatic people, the death rates and the morbidity is going to seem much worse than the reality in the population. So right now, I can tell you that, and this is from the CDC,
Sure.
that the survival rates for COVID-19, if you're an infant to 19, is about 99.997%. That's almost 100%. If you're 20 to 49, it's 99.98%. If you're 50 to 69, it's 99.5%. And if you're over 70 or over, it's 94.6%. And that is very similar to the H1N1 flu, where the death rate was 1 to 4%. So the survival would be 99% to 94%. The difference between COVID-19 and the H1N1 flu, which was in 2009, is that the COVID tends to get the older population and the debilitated people. The H1N1 flu actually really hit the younger crowd hard. So very, very interesting comparison, very similar.
And what is that prevalence of symptoms right now that you're hearing about?
Well, let me finish with the swab test for a minute, because there's an important point people need to know. Initially, there were a significant number of false positives with the swab test, and it was due to some software in the analysis systems, and also the CDC put out a contaminated kit that was giving erroneous results. But the real problem with the swab test is that within the first 8 days of infection, you have a almost 60% false negative rate. And the reason for that is that, and this is in people who are exposed and then are tested during that period of time. Within 2 to 3 days of symptom onset, you have a similar false negative rate. Okay. Overall, it's about 1 in 5 is going to be falsely negative, all testing for the swab test. That means that 20% of the people tested are actually infected, but are being missed by the swab test. Okay. And the reason I'm making that point is it's important to realize that all the tests we use have certain limitations. And the reason that we're recommending repeat testing, especially if you're symptomatic, is because we want to make sure that we catch you when you're actually shedding the virus. The other problem with the swab test is it can't tell the difference between living and dead virus. And after 10 days from the point of infection, you are shedding virus. If you are, it will be dead virus. That's why the CDC recently reduced their quarantine to 7 to 10 days from 14 days. And that's also the reason that there were reports of reinfection, because some people shed the virus for a long time, but it's dead, it's not infectious. So that's that one. Now, what was the other question? I forgot.
Oh, no worries. I'll just continue with this instead. What is that process of shedding that particular virus?
So the virus gets into your body primarily through your nose. It has a propensity for what's called the nasal mucosa. And when it gets in there, it has to distribute itself through the body. And this is where it gets really interesting. The virus likes a receptor in your body called ACE2. ACE2 is related to blood pressure, the renin-angiotensin system. And we have drugs that we treat hypertension with called ARBs and ACE inhibitors. And what's interesting is when you think about the symptoms, because your last question was kind of about symptoms, you know, you've got people younger than 50 having heart attacks and blood clots and strokes. And you've got kidney failure, lung problems, mental issues. It turns out that the most dense population of ACE2 receptors is on the lining of your arteries. So if you think about it, those organs that have the most blood flowing to them, like the heart, the lungs, the kidney, the liver, the brain, you're going to see symptoms from those because those arteries are being extensively damaged. And that's allowed us to come up with new regimens to treat that, because once the virus gets into the lining of your arteries, it's called the endothelium, several things can happen. One of them is a cytokine storm, where your immune system doesn't realize it's already cleared the virus and starts attacking your own body. And for that, in London, or in Great Britain, they discovered that dexamethasone, which is an old drug that used to decrease inflammation, really helps with that, you know. And then the lungs are a different issue. Originally, people were being put on respirators, remember, and they weren't doing well.
Right.
Well, traditionally, when you put somebody on a respirator, they're laying on their back, okay? But it turns out that the most efficient part of your lungs is in the back of your lungs, not the front. And an emergency room doctor in New York noticed that he thought this looked more like altitude sickness than what's called ARDS. And altitude sickness is when your lungs become leaky and the serum that's in your blood leaks into the tissue and forms these glassy looking lesions in your lungs. So he started putting people on their belly. It's called prone respiration, and they did really well. And so that's now become a standard part of the protocol. And the reason for that leakiness in the lungs is a different kind of storm. It's called a Bradykinan Storm. And normally you see something like that with malaria or Bartonella, some of these other infections, but COVID does that. And there is a treatment for the Bradykinan Storm. There are people that it's called hereditary angioedema, where if they take certain drugs, their lips will swell up and they get, you know, and the treatments for that actually help with the Bradykinan Storm. So I think my message is, see, we're getting smarter about what to do for people. You don't see people dying in the streets like they had videos from China. And the recent surge in hospitalizations is only 20% attributable to COVID. It's typical at this time of the year that, you know, you see an increase in heart attacks and strokes, the stress of the holidays and people partying and drinking and, you know, all those sorts of things. So at the end of the day, for your audience, and there's also ample evidence that there are drugs like hydroxychloroquine, which has been controversial, but the Henry Ford Hospital study was one of the best, and it basically indicated that if you give it to somebody early, it's very helpful, but if they're in the hospital already, it's not that helpful. And ivermectin is an old drug used to treat parasites, and there are many countries that are successfully using that to treat COVID patients. It seems to reduce both mortality and admissions to the hospitals. And again, we're learning these things. There's a little bit of a problem with politics in the research community. You know, you've got people that are emotionally attached to one thing or the other. I think it's just important to look for the best studies and keep that out of there. And people deserve to, you know, try things, you know, just to help them. But I think it's important that that people do take it seriously, and we don't want to just be doing what we call mystery medicine. There has to be some valid data behind it to say this is what you do. But we've gotten very good at it. So now we have all these new modalities that we can use to keep people from dying or even getting in the hospital. And now we've got the vaccine, and I think other vaccines are going to be released in the first quarter. So I think we're at the tipping point here. I think that early next year we'll start seeing, at least within the first or second quarter, things starting to return to normal. with a proper vaccination program.
And I know you talked about those symptoms. What are the most common symptoms associated with COVID?
Well, what we see here is loss of smell and taste. That's the big one. And the other one is mild cold-like symptoms, mild diarrhea. Some people get a headache, but I would say that the one that brings the most people to us is, hey doc, I can't smell or taste my food anymore, and they usually have a mild course. It's just, it comes back. It's just irritating to them, well, it's kind of like a diet. I don't know if you don't eat, not a good way to diet, but
no.
So,
that's amazing. And let me ask you this: what happens if someone's test is positive for COVID-19 antibodies?
So that's a very good question. So that means that they have some level of immunity, and the CDC has indicated that whether it's IgM, which is the first antibody that appears, or IgG, or both, that you have a significant level of protection and shed very little virus. What we recommend is if you're IgM only positive, that you quarantine yourself for 7 to 10 days, because you could be very early in the infectious process. If you have both IgM and IgG, you're okay. You should still wear a mask and gloves and do social distancing, but you're unlikely to infect anybody. That's what the data is saying. But we're fairly conservative on the IgM only cases, and they're very rare. Normally IgM is the first antibody to appear. And the way I describe that to people, it's kind of like taking a shotgun and firing and hoping it hits something. The IgM is not as targeted as the IgG. And remember earlier I said the IgG antibody, which typically in infections occurs a little bit later, is more like a sniper bullet. It's definitely targeted at that particular virus. What's interesting is that with COVID, the IgM and IgG tend to come up simultaneously. They come up together instead of earlier. So if you have somebody with IgM only, it's a little bit unusual, and that's why we keep an eye on them. And then as the infection goes on, the IgM tails off within a few weeks, typically. Although we have people where it's persisted for 6 or 7 months. And part of that is probably because they're being exposed to cold viruses, and the IgM just comes back for a while and then goes down. But the IgG lasts longer and goes down a little bit lower. When I talk about the 73 days, I'm primarily talking about IgG, which is the more targeted version of it. So, your body's smart. It doesn't do things that waste energy. If it's going to make an antibody, it's going to make an antibody that's going for that virus. You know what I mean?
Yeah, absolutely. And what is that infectious process?
You mean, how does the virus work?
Yes, sir.
So that ACE2 receptor that I talked about earlier, the virus has to get into a cell because it is not capable of reproducing itself by itself. So what happens is it binds to the receptor flips and puts the virus inside the cell. Then the virus releases its genetic material and takes over the machinery of the cell to make more virus. So remember that movie Alien, where it's like that. The alien injects the thing into you, you're fine for a while, and then boom, you're making little baby aliens. It's like that,
Wow, amazing. And you talked earlier about the antibodies. If anybody has an antibody report that tests, obviously, as far as positive, are they still immune to COVID?
All the evidence suggests that they have neutralizing antibodies and that they have a level of immunity. Now, you'll notice that papers are being conservative about that, but all the evidence indicates that it's a durable immunity, meaning it's lasting a long time. And there are more papers coming out that are, in very respectable journals that say that the immunity that you develop, the antibodies, it provides a significant level of protection and immunity. So yes, the answer is good.
And is the antibody test that is FDA approved?
There are no formally FDA approved COVID tests, but there are emergency use authorization tests. That's the one you want to look for, EUA right now. And we only use EUA tests. in our laboratory. That means the data has been scrutinized by the FDA, and they've kind of indicated that it's approved for use. Those tests have been given a level of scrutiny that some of the other tests, there were a lot of early tests came in from China,
Right.
and they were not good. They had high false positive, high false negative rates, very bad quality control. The FDA here would not allow that to occur. So that's why we strongly recommend that we use US or European tests that have gone through the EUA.
And what was that quality control, doctor?
The quality control is that there is adequate testing of the performance of the assay for the virus in various situations. So, for instance, for the swab tests, you had to show they had people that they knew were exposed at day 0 through, day 14 of infection to see what the performance is, and what the false negative rate was, what the false positive rate was, what the sensitivity is, which means it doesn't miss people that are truly positive, and the specificity, it doesn't call people negative that are actually positive, no false negatives. So all of that data has to be generated in a controlled environment before it's submitted to the FDA, and then the FDA looks at that data. And that is the general process for any laboratory test, is we do that. And I think that the performance of the assays that we're using, we're extremely impressed with the quality of them. We use an antibody test from Abbott Laboratories. It's done on an automated instrument called the Architect, and it's extreme. That's the one that we use as 100% sensitive and 99.6% specific. And there are other ones from Roche and other companies that are equally as good. So I think the ones that are being used right now in the general community are very good. The swab tests, there's one other challenge with the swab test. I've done thousands of these. When you're putting that swab into somebody's nose and running it to the back of their throat is very unpleasant. And some people aren't aggressive enough in getting the sample. So you can get a false negative from improper collection too. So we're kind of encouraged. Some of the, there was just a paper out on saliva tests where the patient collects it themselves. And it turns out it's equivalent to the nasal swab in performance. So we'll see how that goes.
And you talk about the improper collection. What exactly is that?
Well, in order to perform a test, you have to have a sample that actually has a high likelihood of capturing the target. So if I'm putting a swab in your nose, some people are afraid to go all the way back, right, and they miss one of the more infected areas, the area that's shedding the most. So what that means is that I was afraid to push the swab far in, and I didn't get an adequate sample. So when I run the test, it'll be negative, but the patient's actually positive. Now, a more experienced person would have gone in, spun it 5 times and pull it out, and would have gotten a viral sample. See, that's why there is some skill involved in that. Yes. With the antibody test, it's a blood draw, and that's very straightforward. You either get blood or you don't get blood, right?
That's exactly right. And tell me more about the SARS-CoV-2 serology antibody test being provided with a sensitivity of 100% and a specificity of 99.6%, that is, based on the initial performance evaluations. Is that more reliable than any other test that's being provided right now?
Well, it depends on the purpose. So, for instance, for determining prevalence of infection rates in the community, it's extremely reliable. It is among the best. It's going to help our public health officials more than the swab test, because the swab test is primarily being applied to people who have significant symptoms or who are having to travel. And that's called a skewed or it's a population that we know is going to have a high hit rate, so it'll be misleading. So the antibody test is very important in that regard. The antibody test is part of the routine practice of a laboratory. We draw blood all the time. Swabs, the other thing I want to reiterate is the antibody test is not used for acute diagnosis. If you've got symptoms, we don't do the antibody test. We tell you to come back in 14 days and then we'll do it, because you're past the infectious point. You'll have developed antibodies. If you're right in the midst of your initial phase of the infection, the earliest that we've seen antibodies is about 2 days after symptom onset.
Okay.
And the median is about 5 days where they start to appear. So we want to get you somewhat after that, so we have a better likelihood of knowing whether or not you really had that. Okay.
And what is that high hit rate that you're used to seeing?
Well, if you've actually had the virus and you have antibodies, we will detect it. Now, I will tell you that the cutoff points for the virus, for instance, I had somebody that had an infection in April, and when they came in and we did their serology, they were positive initially. When they came in 5 months later, they were considered negative, but their value on the test was like, I think, 0.63, and all the true negatives are like 0.06. So they were on the drop off. It's that 73-day half-life, but we knew they were positive. So, but it's a really good test.
And what are those values that you usually see?
In terms of what do you mean?
What you just said, when people come in initially positive and then they come out negative.
Yeah. So we've done thousands and thousands of patients, and the negative patients are all less than 1.4 is the ratio cut point for IgG.
Okay.
And for IgM, it's 1. But the true negatives are mostly in the 0.0 range, whereas the people that have had antibodies and it's dropping off usually are, 0.1, 0.6, 0.9, that sort of thing. But we don't actually report out the ratios because it confuses people. Yeah. We report out positive or negative. That's it.
And this is a question that I really wanted to ask you, Doctor, because it's out there. You probably heard it before. Listerine, apple cider vinegar, that is. Are there any natural medicines that are aimed to help to reduce an individual from getting the actual coronavirus?
There absolutely is. And that's not the ones you just mentioned.
Okay. Oh, wow.
I will tell you that gargling with salt water or Listerine is actually helpful.
Wow.
I don't know about apple cider vinegar because that cures everything right now.
Right.
To people. Sorry. The thing about it is vinegar is a natural antiseptic. So yeah, in theory it could. I just don't know how well it is at inactivating the virus, whereas Listerine it'll kill anything,
Right. Exactly right.
But there are natural things that will help. And one of the more important ones is vitamin D, because the COVID virus, number one, damages the receptors in your body that help you use vitamin D, and it also increases enzymes that destroy vitamin D. So we recommend that you're taking at least 10,000 units of vitamin D a day during this period of time. And the other thing that works is quercetin and zinc in particular,
right,
and vitamin C. Those are all easy to take. And then there are some things that boost a compound in your body called glutathione. Okay, glutathione is the master antioxidant in your body. It boosts your immune system, and it helps you use those other vitamins. So in other words, those vitamins don't work as well if you don't have enough of it. You can get that from taking a supplement called L-citrulline, or you can buy a compound online called Swish 30. It's a liquid. You swish it in your mouth for 30 seconds and swallow it. And it has a number of supplements in it that help boost glutathione in your body and boost your immune system. And these are over-the-counter nutritional supplements, but they're evidence-based. In other words, the components in them have been shown to work in other studies. And just to be clear on this, I do not work or endorse any company's supplement products. I've never taken a dime to promote anything. I don't work for any of these companies. So if I'm talking about something, it's because I use it personally. Okay.
And what type of evidence is there out there when it comes to the Latino community and African American community, that is, when it comes to COVID?
So it's interesting. Nationally, the African American community infection rate was reported to be around 18%, and the Hispanic community was maybe even a bit higher. And when we did testing in, for instance, South Central LA or Crenshaw Hills, we found something really remarkable. The African American community was in the 2.9 to 4% infected rate, and the Hispanic community was still up there in the 14 to 18% range. And I attribute it to the fact that in the areas that we tested, there was an active community outreach program to the African American community, teaching them about hand washing, masks. They also provided free masks and free antiseptic solutions to the community, and taught them about social distancing, and it worked. You know, it worked in that group. Now, the difference between that and the Hispanic communities have multi-generational houses where they have 2 or 3 generations all living in the same house. High concentration of people. The Hispanic community tends to be in the service industry. They tend to be exposed to more people. And because of that multi-generational concentration of people in an individual house or apartment, if somebody brings it home, they're more likely to share it. Okay, that is what the sociologists and the chief science officer at the LA County Health Department are attributing it to. But I guarantee you, because I did a radio show with some of the community organizers in the African American community, they were very dedicated. They were out there and they did a great job. They actually came to our events and brought water, and I did a couple of TV interviews with some of them, and they were very committed, very smart people that were really out there helping people.
That is amazing.
Yeah, it is. And we're trying to get that to other communities now that we know that that works, you know.
Absolutely. Well, Dr. Douglas Harrington, thank you so much for your time. And again, welcome to the award-winning Quintin Close-Ups.
Well, it's been a pleasure, and I hope you continue to enjoy that nice weather there for the time being. Okay.
Oh, yes, absolutely. And I hope to have you back on Quintin Close-Ups in 2021.
Anytime.
Oh, great.